1 year. 1:4. Yes. Yes, please.
So I'm at 1:4.
I would like to first of all, I'm Dr. Abdullah.
Sir, I can't hear you. If you can just.
I'm Dr. Abdullah, fourth year resident at PKLI. Regarding the general surgery training, 1 year or 2 years, it would matter if the training is sufficient enough. The candidates are taught tissue handling, bowel handling enough. Being a trainee and seeing my other colleagues, I have seen that the institutes are very deficient regarding to the rotational trainees. They don't teach them as such. Like they know this candidate is from urology, he's in general surgery just for his rotation. They won't let him touch and do it.
So, do you
So if it's 1 year or 2 years, would it matter?
Yeah, I mean, 1 year. If you make it 1 year, and you also, and this is what actually my plan is. That's what I keep on telling, that at 1 year, you should have a structured training. You should not be left 1 year totally for the general surgeons, because what would he gain if he just retracts for a cholecystectomy, or if he does something, helps the sister surgeons with thyroid? That's not going to help him. So the idea is to give them a structure. The ideal would be the rotation that I suggested. It may not happen, but at least I'm going to suggest that. I've been suggesting that. But the second thing is to make that 1 year structure. There should be objectives. Why is he coming to surgery? He's coming to learn bowel handling. He's coming to learn, if possible, some vascular surgery. In that firm, he goes to another firm. Yes.
Right. Thank you.
Yes, please.
I totally agree that the resident should be spending as much time as possible in actual field that which he wants to do. But how should we standardize the clinical model? Because a resident who wants to go to urology versus a resident who wants to go to, for example, neurosurgery, he would be having different sort of rotations, and this guy would be having different kind of rotations. So, but the exam intermediate for you would be the same for everyone. So I think there would be some residents who would be passing that, and there would be many who would fail that intermediate module.
Yeah, what I'm trying to say is to have a totally different 1 year training of IMM for urology, totally different. It's not going to be among those two groups.
Exam would be different as well.
Exam will be different as well. Yes, yes. Because it's just a waste of time spending 2 years when you've been through that, and most of you feel that you wasted your time in 2 years there.
But I mean, I still feel like why is urology training for 3 years? Those 2 years in general surgery is totally wasted. The reason being, in that unit, people consider they are going to urology. They don't focus on that. Secondly, neither they are interested. Thirdly, they would not be focusing on their real training in general surgery. I still go back to those old school of thought where you do first fellowship in general surgery and then you opt for like American system. You become a board in general surgery, then you go for training in there. Because you must know vascular surgery, general surgery, and any other. So I still feel their basics like general surgery should be very strong before moving to either urology or any other specialty.
So basically suggesting that it should be 2 years.
I feel 2 years. 2
But
years
if there is general surgery for 2 years, that has to be really structured, but will be falling short of urology training. Ideally, okay, fine, 2 years of general surgery and then 4 years of urology. That's not possible. You have to have a compromise. Either you have 1 year of general surgery and 4 years of urology. Either you have 2 years of general surgery and then 3 years of
No, I'm
urology.
not comparing our training with the American training. Why shouldn't we have a better training? If they say well, you should have a good general surgeon, then you opt for a specialist training. And their specialist training is from 3 years to 5 years. So what I mean, if you have got 2 years of general surgery and then 4 years of urology.
Yeah, that is difficult. Ideally, that would be fine. But if there is Dr. Reza from the US, I don't know whether he's here or not, But I believe the new system of urology training in the US is that they directly go into urology. They have stopped that thing, and they've probably got the modified training program or something.
Just a counter argument. Our gynae colleagues, as an example, they don't go to urology even, they don't go to general surgery even for a single day, but eventually they become extremely good gynecologists. So why can't our residents, for that matter, why do they need general surgery for that matter? Can't we teach them the gut handling or vascular handling for that matter?
Yeah.
As far as
That's a counter argument.
As far as I know, the gynecologists in our centers or any other center where in Peshawar I've worked, even in UK I've worked, the gynecologists, they don't know anything out of their specialty. Like if there's a ureter, if there's a bowel, they won't be able to handle it. I think they should know little bit of the general surgery and urology.
I agree.
I still feel they should be very good general surgeon first.
I agree that we can't copy paste every system to match our system, but we have to keep in mind what we have here. We cannot have 2 years of general surgery, and we cannot with 4 years of urology. We can't have that. Under circumstances, if we have a choice of 1 year of general surgery, that too structured, and then we have 4 years, I think is more acceptable.
Sir, yes, sir. Adding into the Professor Atta observation, 2 4 seem very good. लेकिन सर और हमको पता है कि when it comes to the financial implications of the PGMI or any hospital which is paying the stipend to the residents, वो नहीं मानते. तो आपको 4 year रुकेंगे, ये तो 6 year हो गया. तो देर से कि ये हमारे साथ 5 year का प्रोग्राम है, वो या 1-4 करें या 2-5 करें, छठी हम नहीं देंगे.
कंप्रोमाइज करने लगे तो ठीक है उसकी, लेकिन आइडियल ट्रेनिंग
Under circumstances you go there. Lekin as I gave you the example of US, so we're not totally different off the track. I know that you're such a versatile surgeon. I want to be impressed by you because you're a professor of surgery and then you change your career and became professor of urology, and there's nothing that you can't do. Okay, so 1 year. Okay, we move on. So this is what it is. I'm just sort of giving you a description of what we have proposed to the CPSP rule that we accepted. First year, now we're talking about 4 years. Okay, so 1 year is gone, 4 years. So the first year will have introduction. Sorry.
Yes, sir. एक सजेशन थी कि जो जनरल सर्जरी की रोटेशन है, जब हमारा कैंडिडेट जाता है फ्रॉम डे फर्स्ट जनरल सर्जरी, उसे पता ही नहीं होता कि मैंने किस चीज़ पे फोकस करना है. अगर यूरोलॉजी पहले 1 साल करे वो, उसके बाद जनरल सर्जरी जाए, तो वो अपने कंसर्न्स प्रॉपर देख सकता है कि मैंने किस चीज़ पे फोकस करना है, वरना तो वो अपेंडिक्स और हर्निया करके आ जाता है.
And I think most of the people would not agree. If you have to have general surgery, it should be at the beginning, where you talked about the general surgical principles, and so I think that can't be changed. Okay, so coming back to the first year, introduction, basic principles, infection control. There was a nice talk by a young lady about infection. I can tell you the infection is rampant, at least in KP. There are organisms which are resistant to everything. They're pan-resistant organisms. So there are things these should be put in mind. How do you are part of the principles of surgery, how to have an idea of infection control as well. And of course, as the candidate will be sitting his IMM of same as before, 2 years. 1 year would be the general surgical time year, and the next year would be the urology. So he have these 2 years. So he'll be sitting exam in the first year of the 4 years training program with urology. So he should have some time for IMM. He should also be helped by his supervisor and have time to select a topic which he will require as one of the requirements for the exit exam. There was a dissertation, but now they've accepted that it can be an article in an index journal with a certain impact. Learning on simulators. Simulators are available almost in every big city. If there is a facility, why not use that? We have in Bishar, and in the first year, while they're learning the principles, they're preparing for IMM, they're started with some work on the research, they can also go and visit the simulators. Second year, obviously, they progress to higher levels of knowledge and skills according to the competency chart. I don't know how many of you know the competency chart. I won't be surprised if you've got no idea about it, because this is something which is the supervisors, and supervisors, I don't think so discussing these things, but I'll show you what the competency chart is. Then there should be internal rotations, lithotripsy, urodynamics, and they should all be defined. It can't be left to the supervisor कि जी आपकी मर्जी आप जब इसको बिछवाना चाहे वो कभी भी नहीं जाएगा. They should be clearly defined कि फलाने महीने में for 6 weeks whatever this guy is going to go to the lithotripsy unit or the urodynamics. External rotations, ICU, radiology, nephrology, peds, urology, or any other training required. So this will be between 2nd to 4th year. I've left out the detail of every year, but from 2nd to 4th year, this is how it goes. You keep on progressing as far as skills are concerned. You have internal rotation initially, and then external rotation not in 1 year. They will be split on in those 3 years, and this 3 years, yes, which will be ICU, radiology, nephrology, peds, urology, and any other deficiency which the parent unit feels there is. Any idea about curriculum? कितने लोगों ने यूरोलॉजी का curriculum देखा है? इसमें मुझे हाथ उठा के बता दें. So out of the whole lot, Shahzad, I'm talking about the trainees. Trainees ने कितने curriculum देखा हुआ है? 1, 2. So out of the whole lot, there are only three people who have seen what the urology curriculum is. This tells you how senseless the training is. In terms of the supervisor, he's not using the curriculum as his guide, and you have got no idea what you are supposed to learn. And obviously, the objective of training. One of the gentlemen here was saying that by the end of the day, what the objective is of this training, to have a safe urologist. So I'll come to that point as well. So syllabus, actually, the curriculum is the whole stuff, the whole book, which has got everything, which has got syllabus, and syllabus the syllabus contains different topics. It also has a competency chart, which is for knowledge and skills. So if you lay your hands on curriculum of 23, we hope to revise that this year again. So go to the page 19 onwards. That's where the syllabus is. वहाँ पे आप लोगों को पता चलना है कि आप लोगों को क्या पढ़ना है और क्या आपसे expect किया जाता है exam में. So if you go to page 19 of curriculum, where would you get the curriculum from? Go and ask the supervisors. They can access the curriculum. Competency chart, go and have a look at page 31 and onwards. उसमें हर साल की competency दी हुई है, उसमें ये लिखा गया है, this is in it, that what is expected of a trainee in terms of the procedures, the numbers, year-wise. This is how the competency chart looks like. Again, I bet nobody has got an idea how this looks like. ठीक है? ये वाला जो है, this is for year 1, year 2, year 3. And just to clarify, L1 is observer status, L2 is L is actually observer status. L is the level of training. 1 is the observers, 2 is the assistant, and so on and so forth. So what is the objective? This is what the CPSP competency model is. They have got these 3 headings: advocacy, pedagogy, and professionalism. And under that, they have written advocacy means knowledge and clinical thinking, technical, and so on and so forth, and described here. What happens when you are sitting your FRCS exam? The gentlemen who are here, who got their exams, who worked there, it is actually a day 1 consultant is in their mind. ये बंदा जो है, ये बंदी जो है, ये day 1 consultant में कैसे काम करेगा? ठीक है, एक day 1 consultant का उनके दिमाग में जहन होता है, उसके लिए assess करते हैं. जो आपका objective ही नहीं है examiners का, they can ask you anything from anywhere. They might be just looking weakness in yours. They might be trying to impress you with their knowledge, and unfortunately that does happen now and then. But if they have an objective, कि जी इससे आपने इस चीज को जहन में रहे कि आपने exam लिया. This is what I've been trying to tell whenever I'm the convener of examination, and I've repeatedly asked the college to have examiner courses. This is where you learn these things. So basically, consultant urologists fit to enter a safe core practice. These are the words from the FRCS exam. this is what they have in mind. I have just put it in a different way: sufficient knowledge and appropriate skills to be a safe urologist who can start practice as a junior consultant, dealing with condition he or she is capable of. So what do you think about the standards of training? Is it good, satisfactory, bad? How to improve it? Do you have any idea of what the feedback system is? I think we are really short of time and there aren't any hands being raised, so I'll just carry on. So, yes, most of the people do feel it's suboptimal. So why? What are the reasons? I've just put a few things down here. Curriculum. Is it effective? Is it being implemented? You've got an idea from the show of hands that only 3 people out of this whole room even knew about the curriculum or have seen the curriculum. So इससे तो आपको अंदाजा हो गया कि curriculum की effectiveness implementation कहाँ पे बढ़ी हुई है. Supervisors, they may not be updated, they may have poor teaching skills because they have learned, they've attended their supervisor workshops, and that was when they became supervisors. 10 years ago, 20 years ago, there was never a refresher course. This is what we've been trying to tell the college, there should be refresher courses, and they have agreed, and they've indicated, yes, people can go, and there's refresher courses going on, but obviously this has to be implemented. Is lack of interest? Yes. Organization? Yes. Lack of interest इसलिए होता है कि not that they are mean to you, they don't want you to benefit, but they're just too busy. Just too busy. They might be coming to the hospital 10 o'clock, and they've got patients to see, and then they've got their claims to run. So this is what it is, lack of interest in organization. Trainees, they're overcrowded, lack of interest, poor time management. So this is also, I feel this is supervisors' job, what to do it. If they're overcrowded, divide them in groups, send them to other consultants, send them to rotation somewhere, and there's so many things can be done. We cannot overnight come with more training centers because there's a limitation. I can tell you the statistics of a couple of years ago, there were about 1,500 students or doctors who had passed their part 1 and they didn't get into any training program. 1,500, and that's increasing. Institute, yes, there's a variety. There's no standardization. There was a discussion of standardization. That is true. Some places are at par with any center in the world. Others are just lacking the basic facilities to the point of not even having a basic endoscopic equipment. What can be done? The only way forward is I will come to that. We'll come to that later on. So please. Sorry. Okay. Feedback and it's not fully implemented. What else is training? This is the most important question that I have on mind. ये बातें तो हो गई, कुछ बता सकते हैं इसके अलावा आपकी competencies हैं, आपकी knowledge है, सब चीजें हैं, उसमें और भी चीज क्या रिलेट करती है कि आपकी ट्रेनिंग में? Research. Yes, research is there, but I had something else in mind as well. Research, they are trying to cover it up by asking, पहले dissertation थी वो खत्म हो गई, and now they come to a paper. So that's a sort of just touch. Obviously, there was always an idea that there should be 6 months of research, but we can't afford that because of lack of period. So there's no teaching, there's no personality grooming, there's no talk about mannerism, there's no talk about behavior, compassion, empathy, moral ethics. So unfortunately, we might be churning out doctors who are just concerned about how to learn things and how to practice them and how to have monetary benefits. Measures to improve the training. What have we done? It's been revised last year, trying to revise it again. Good standing of supervisors. There is a document which was circulated to us. That was something which was extraordinary to the extent that it might be difficult to implement, but it hasn't been implemented as yet. So supervisors की good standing होगी तो उनको allow किया जाएगा. और उस good standing में सारी points हैं कि ये चीजें check होंगी उनकी. अगर उनमें हैं तो फिर उनको आगे इजाजत दी गई. But it's not been implemented because it's a very complex, and they've suddenly started from all and none wale principle. They should have gone somewhere in between the two. Re-accreditation of centers. This is again been repeatedly asked. And the college has agreed, but they haven't come up with things. आपको जाके you have to accredit because standardization की बात जो हो रही है कि इसी से होगी कि जाके visit करेंगे, उसकी minimum criteria होगी और जो उसकी जो कमियां हैं बताई जाएंगी. This is the only way. You cannot totally disaccredit a training center because we already lack them, but we can certainly categorize them. And we tell them category will go on to 2, 3 when we come next time. Meanwhile, there will be rotations arranged, and MOU, the college should be able to check the MOU signed by that supervisors with other places and see if those are being implemented. Feedback from supervisors, yes, if supervisors have got a portal, they can give feedback on you. And but I was interested, what about the trainees? They should be able to give feedback as well. So I was told, yes, that is there. Aapke e-portals mein hai, lekin it's not been activated. So hopefully that will be activated. That is so important. Assessment. So I don't think this is the best of the feelings. The candidate being the cat, of course. Areas of improvement related to the examiners and the conduction of exam. जैसे मैंने आपको शुरू में कहा था कि the objective has to be made clear to the examiner, and how do we do that? That is the examiner courses. I had been at it, and they finally organized some courses, which was not what I had in mind. They had about 300 people invited, and they were trying to teach 100 in one hall. So I don't think so that was the way forward. So they've agreed that they will do something about it and make it more sensible, civilized. एग्जामिनर ये सारी चीज़ें जो है एग्जामिनर को आप बतानी पड़ेंगी तो उसके दिमाग में आएगी. I've been trying to tell them whenever I'm a convener कि उसमें आप जैसे वो हम कह रहे थे ना कि आपका ऑब्जेक्टिव क्या है कि एक ड्रिवन कंसल्टेंट के उसकी क्लिनिकल एबिलिटीज को देखें कि भाई is he able to practice as a good clinician, as a good urologist, rather than you go into the nitty-gritty. Of course, you go and ask some very bookish questions to see if he how well aware he is with the text, but that would be for the end, for the brownie points, not for the to start with. कि आप शुरू से उस पे शुरू कर देंगे जी DTP की मुझे एब्रिविएशन किस चीज़ की DTP किसकी एब्रिविएशन है, that's it, he's derailed. वो इधर चला जाता है उसके दिमाग में अगर कोई आधा DTP होता है जी क्वेश्चन मेरा ठीक नहीं हुआ. Opportunity to examine broadly. Don't stick to a point. This is what I've been trying to hope to put this in mind. We've been putting in mind, and hopefully that will be the part of examiner. एक चीज के पीछे आप फंस जाते हैं, उसी पे आप एग्जाम खत्म कर देते हैं. You have to see the breadth and the depth of exam, of the trainee's knowledge. So minimize the bias. In terms of content, long case जो है वो उसमें एक मैंडेटरी की हुई है, कंसेंसस की. पहले दोनों एग्जामिनर्स अपना बैठ के वो करते थे, and they would just start with the questioning without any consensus कि इसमें क्या हमने questions पूछने, what do we expect, etc. So that has been introduced. Talks, preset questions is already structured. Case-based scenarios have been introduced, and I would like to increase the content of case-based scenarios, replacing quite a few toll stations and also of short cases. Why? Because the short cases, you cannot have many short cases in urology. It's a very intimate examination. You just cannot have even the people who have been examined for varicocy, 8 of the candidates come. How would a person feel to be examined by 8 candidates? Okay, so this has to be stopped, and case-based scenarios will be put in. Again, the depth and the breadth will be achieved. Logbooks and dissertation stations we've introduced, because पहले logbook भी आप बनाते थे और dissertation भी आप लिखते थे, उसमें कोई पूछने वाला नहीं था. So there are stations now for the logbook and the dissertation, and those are discussed. A workplace-based assessment has started. It's been implemented from this January. The idea it should become the marks obtained in the internal assessment should be marks in your final results. So this is the ultimate plan. So I won't take too long. I'm about to finish. Measures taken as examiners, as I told you, examiner courses. Those are being they were conducted, but they have to be more organized, and more sensible, and more civilized. So we have to have this objective and all these other things. Etiquettes, examiners' etiquettes. We all have big complaints about that. ठीक है? किस तरीके से बात करते हैं, किस तरीके से उनकी शक्लों की appearances change होती रहती हैं, and so on and so forth. And again, the ability to get the maximum out rather than sticking to a point or two. content related, as I said, reducing most case-based scenarios, reduce short cases, modify long case. Yes, trying to get rid of the long case. 1 घंटा लगता है एक prostate पे, 1 घंटा लगता है एक renal cell carcinoma पे. Why can't we have this examination and history moved on to the tools, basically psychomotor hai, and the time left here you can have a couple of case-based scenarios. ठीक है, बाज़ लोगों पे they have done away totally with the UK में भी है, Europe में भी है, probably US as well. You wouldn't be taking history and examination, but we can't afford that because you know training is not as good, and if you let that go तो पहले भी students से नहीं उठते हैं, patient साथ बात करते हैं तो they will stop examining it. Talks, as I said, talks पे ये introduce किया history and examination introduce करना है. So what is the final product that we're looking at? A better person, refined, well-mannered, easily approachable. वो ना हो कि जी शिकायत होती है, डॉक्टर साहब ने बात ही नहीं की, उससे बात ही हम नहीं कर सकते हैं, ठीक है? So this is better person. He should have empathy, compassion, and strong morals, not running after this and that, and lured into all these other monetary benefits. Sound professional, he should have an updated knowledge, skills, and knows how, and also knows the limits of his capabilities. This is so important. You should know where your capabilities stop. Either you seek help, either you send it to the right person. Don't mess around. ये कोई गाड़ी नहीं है कि खराब हो जाएगी उसके दूसरा पार्ट आप उसमें लगा देते हैं. He's cooked for life. Research, of course, he knows and touches it. So that's all. Thank you.